Hello everybody, today we're going to be doing a laparoscopic chole. I'm going to go ahead and show you my notes real quick. So this is a 34-year-old female. She's a BMI of 25. She comes in for right upper quadrant pain, diagnosed with cholecystitis last night. She's been NPO since midnight. So I'm going to proceed to do a pre-op assessment followed by the room check, and then we're going to have her procedure done. So I would introduce myself. I would explain the procedure that we're going to be doing today. I would get a medical history. I would go through every body system. Neurologically, she's intact. Cardiovascular and lungs, she denies any problems. She denies any smoking, any kind of illicit drug use. I would auscultate to the lungs and the heart, no murmurs. She denies any kind of reproductive problems. We did an HCG test that was negative. She denies any kidney, liver, GI problems other than this one incidence of right upper quadrant pain. We did a set of labs on her, and her BNP and her CBC were normal. No issues other than elevated WBC count related to more than likely her cholecystitis. And so I would explain the risk versus benefits. That includes any chipped teeth, sore airway. She would have benefits of, she would have a positive experience overall. I would ask for any history of PONV. Does she have any history of nausea, motion sickness? She denies that. ASA class, since this is her only condition, she's an ASA class 1. We're gonna go ahead and do an oral assessment. So we're gonna look at her intercisor distance is 3, thyromental distance is at least 6 centimeters. She has good motion on her neck. Melon patty is 1. I can see all her structures. She can do an upper lip eye test that's indicative of easier airway. And so once we do that, we will take consent. We've done risk versus benefits. ASA class is assigned. Post-op nausea has been covered in terms of we get her history. We want to go ahead and go set up our room. We would also want to check allergies. We want to make sure that she doesn't have any allergies, any history of malignant hyperthermia, any kind of neuromuscular diseases, familial history. Has she had general anesthesia? She denies that as well, but no familial history of malignant hyperthermia. So I think after she has her IVs, we're gonna also make sure she has 2 IVs. We're gonna go to the OR and set up our room. We've checked all our pressures. We have all our airway supplies, our apples, emergency supplies, rescue supplies. The machine's been checked, so we are good to go on that. So after that, we would bring the patient over to the OR. We would have her in the supine position. We would pad all her pressure points, making sure that we prevent any kind of pressure injury. Great, so after we've done that, we've had her, my tech has set up the nurse has set up the monitoring, so she's on all our monitoring, including EKG, SpO2, blood pressure cuff. So we're gonna go ahead and hyperoxygenate her, denitrogenate, turn on her gas flows, have her take some deep breaths. Looking at her monitor, she's at 100% on the monitor. So do EC technique. Like I said, we have all of our induction meds ready. So we're gonna go ahead and denitrogenate. Once that has been done, we have our MAC blade, we have our ET tube. We're gonna go ahead and push our induction meds. So I'm gonna go ahead and give 100 mics of fentanyl. She weighs 70 kilograms. We're gonna go ahead and do 140 of propofol. And then we're gonna go ahead and do 40 of lidocaine as well. And then we're gonna go ahead and try to give a breath. While the APL valve is open, we're gonna try to give a breath, making sure that we are able to get a good end-tidal CO2 waveform. Now I'm comfortable pushing my paralytic, so she's gonna be getting 70 milligrams of rocuronium. So she's gonna be getting laparoscopic procedure. So that's been given. I'm gonna let the paralytic kick in. That's great. So I'm gonna go ahead and get my MAC blade. I'm gonna do the scissor technique, and then I'm gonna sweep the tongue from right to left, making sure that I'm not putting a lot of pressure on the teeth. And I'm gonna go ahead and advance the ET tube. Once I pass the cords, I'm gonna take out my MAC blade. I'm gonna go ahead and take out my stylet. I'm gonna go ahead and fill up the ET cuff. So that is filled. I'm gonna go ahead and connect her to my circuit. and make sure that I have the appropriate, I'm gonna auscultate, I'm gonna give a couple breaths, I'm gonna auscultate bilaterally. I'm gonna look for fogging of the tube and tidal CO2, making sure that I'm getting a good capnography, checking over the stomach, making sure that it's not in the stomach. I'm gonna go ahead and put her on the mechanical vent. I'm gonna turn on my gas to 2%, and then I'm gonna tape her eyes. So eyes are taped. The depth of the AT tube is 21 at the teeth, and then I would kind of secure the tube in place at this point. So at this point, she's paralyzed. She's gonna be riding the gas. The procedure should take about an hour and a half. And so about midway through, it's been about midway through the procedure. I'm gonna check my train of 4. I'm about 2 out of 4 twitches, which is an adequate level of neuromuscular blockade. I just wanna mention that I do have my Sugamidex here just in case I need to reverse my rocuronium, and I'll be checking again as we approach the extubation phase. So the surgeon's closing up at this point. I'm monitoring my FA-FI ratio of volatile, and they're probably about maybe like 30 minutes from closing, maybe a little less. So I'm gonna go ahead and turn off the gas. The gas is off, and I'm gonna go ahead and I'm gonna wanna do an awake extubation versus the deep extubation. Awake will preserve the airway reflexes rather than the deep. And so there's a high risk of laryngospasm with the deep extubation because they're not really able to preserve the airway. They're not able to really cough. So it's really important to, in my instance, I'm gonna do an awake, and so I want them to be opening their eyes. I'm gonna have them squeeze my hands, making sure they're able to follow commands. So at this point, the gas is pretty worn off. The eyes are opening now. You did great, procedure went well. I'm gonna have you squeeze my hands. So they squeeze my hands. So we're gonna get ready to pull the CT tube out, okay? So I'm gonna go ahead and deflate the cuff. I'm gonna just suction you out really quick, really good, making sure that we don't want any kind of stimulus on those vocal cords. So she suctioned out really well. I'm checking my train of 4. I have 4 to 4 twitches. So I'm comfortable that there's no residual blockade. So I'm gonna go ahead and pull out the ET tube. I'm gonna deflate the cuff here. All right, we're gonna be pulling it out. Ready? 3, 2, 1, it's coming out. Great. She's coughing a little bit, that's good. Eyes are open. You know, she's clearing her secretions. I'm suctioning out. That's good. Great. Tolerated her well. Also, she did get a 4 of Zofran, 4 Decadron for postoperative nausea, just in case. And we're gonna go ahead and wheel her back to the PACU. I'm gonna be giving a report. Estimated blood loss about 50 cc's. She did receive 100 of fentanyl, 100 mics of fentanyl, 140 of propofol, 70 of rocuronium, 4 Decadron, 4 Zofran for PONV. She did put out about 60 cc's of urine. She got 4 to 4 twitches. She's on room air. I didn't have the need to really put a nasal cannula on her after. She's coughing up her secretions well, taking deep breaths, following commands. She denies any pain. Procedure went well. So at this point, we would, that's about it really. I would just give her history, making sure that I give her history. Like I said, not anything significant at all. ASA class 1. We did all our volumes, blood loss, urine. Intraoperatively, she was just getting minimal rate with the infusion. So she might have got about 500 cc's of LR throughout the case. Her IV sites, her vital signs, they're stable, heart rate, blood pressure, SpO2, all adequate, very close to baseline, no fever. So at this point, I'm comfortable handing him off to the nurse. I would answer any questions. And that would probably be about it. Thank you so much.